Let me introduce myself. I am Dr. Tamer Roushdy, Assistant Professor of Neurology at Ain Shams University, Cairo, Egypt. First of all, I am very pleased to participate in MINESO Congress, and I hope that we may meet physically soon after defeating COVID-19. My presentation is on the Egyptian experience with COVID-19 and stroke. This is my disclosures. First of all, let me introduce our enemy, a severe acute respiratory syndrome of coronavirus 2, which is abbreviated as SARS-CoV-2, emerged in Wuhan province in China around December 2019. It was not yet until March 2020 when it was declared as a pandemic by the WHO. Since its declaration, more than 241 million have caught the virus, with more than 4.5 million deaths. What makes SARS-CoV-2 a challenging virus is that it does not affect only the respiratory system, but it also may affect other body systems, including the nervous system, which is in the core of such infection. Moreover, the virus is a novel virus to the human immune system, and the human body immunity react to it in a diverse response, with some patients requiring hospitalization up to intensive care unit admission, and this places healthcare systems under continuous pressure. Around 33% of individuals who catch SARS-CoV-2 have neurological manifestations, whether central or peripheral. Although there is no official numbers speaking on SARS-CoV-2 and strokes, yet all of us have witnessed cases having a positive PCR and stroke, or just recovering from COVID-19 with a positive IgG and a negative IgM, and they developed a stroke, and some of them have no explainable modifiable vascular risk factors. Along the coming slides, I will pass along Egyptian experience with COVID-19 and stroke. Yet before beginning my publications regarding COVID-19 in the Egyptian perspective, let me first pass with you along this curve, which is representing the official numbers of COVID-19 cases in Egypt and the three waves. And currently we are along the fourth wave of the COVID-19 as well. Egypt and Ain Shams' journey or experience with COVID-19 passed through 7 publications. The first one was under the term Stroke in Time of Coronavirus Disease 2019. Second one was a case series of ischemic stroke cases with coronavirus disease 2019. A review on SARS-CoV-2 and stroke pathogenesis and outcome was our third publication. Global impact of COVID-19 on stroke care and intravenous thrombolysis was a multi-centric study that Egypt participated in. And pre-hospital causes for delayed arrival in acute ischemic stroke before and during COVID-19 pandemic was our fifth publication along the experience with COVID-19 and stroke. The sixth one was a case series of post-COVID-19 mycosis, and finally SARS-CoV-2 and stroke characteristics, which was also a multinational COVID-19 study group. During our journey hand by hand with COVID-19, we tried to knock on all possible doors. We aimed at saving lives and saving time, study stroke and COVID, maintain our performance, and assess any decline, and of course correcting it. Our first on the run stop with COVID-19 was our publication, A Stroke in the Time of Coronavirus Disease 2019, which was published in the Journal of Stroke, and it was actually prior to the declaration of the pandemic. Since Egypt, waves are usually occurring secondary or along third point with Asia first being encountering COVID-19, Europe began to encounter COVID-19, and then the wave will appear in Egypt. And this was similar along the different waves. And so we were following what is taking place, for example, in Italy, and we decided to change our pathway or modified our pathway so as to maintain two goals. First, the lives of the patient to be maintained, as well as the life of the medical staff, and also saving time was another goal, since time is brain. So providing ultimate therapy, including thrombolysis and thrombectomy, was to be maintained by any means. This is the pathway which we modified. Initially, we usually meet the patient along the ER and perform then CT brain. And after performing CT brain, we will assess the time of onset and time of arrival, and we'll divide the patient into three pathways. Either the patients who are arriving beyond a window of thrombolysis or thrombectomy, or those arriving within a window of thrombectomy but beyond the window of thrombolysis, or those arriving within window of thrombolysis and thrombectomy. But because of COVID-19, we were pushed to administer also CT chest as well as swabs and labs prior to administering any thrombolysis or thrombectomy for the patient. So initially, the patient were being assessed in the triage. Suspected cases by history that they are suffering from COVID-19, for example, having fever, sore throat, dyspnea, cough, or any constitutional symptoms, were ordered swabs and labs and CT brain and CT chest, and then they were classified into either one of three pathways. Those beyond the 6-hour window were admitted to isolation unit until the result of the swabs, or those within the window, either thrombolysis or thrombectomy, will receive their optimum treatment and again will be admitted to an isolation unit until the result of the swabs. The results of the swab will then pass the patient along two pathways, either positive swab that is transferred to the quarantine hospital, and I am glad to declare that Ain Shams University was a pioneer in this field, where Ain Shams provided three different and separate quarantine hospitals beside the ordinary university hospital and specialized hospital that are dealing with COVID-free cases. And those patients who are negative by the swabs are transferred to the stroke unit, where they will pass along the usual protocol to assess the causes behind the stroke and provide secondary prevention. And along 1.5 years since official WHO declaration of pandemic in March 2020, the pathway is running with no single patient in window being lost. Yet secondary to virus different strains and not more than 70% sensitivity of PCR, breakthrough in admission of COVID-19 cases occasionally occurs. Yet transfer to quarantine hospital takes place on regular basis. The second experience, or the second publication, was a case series of ischemic stroke with coronavirus disease 2019. Although we are a COVID-free hospital and we only deal with the COVID cases once encountered in the ER and the isolation unit prior to transferring the patient into the quarantine hospitals, yet we usually meet such cases, at least cross-sectional meeting. And along this case series, we provided 10 cases were presented in 2020 along the first wave. 7 cases received RTPA with an average door to needle time 30 minutes, which I think is an optimum time of injection. Despite suffering COVID-19 and fear of catching COVID-19 by the medical staff themselves. One case has an excellent recovery with MRS 0. 5 cases had an MRS less than or equal to. 2 cases had an MRS of 4, and unfortunately 2 cases died. Out of this case series, I think it was one of the first case series to represent RTP injection in COVID cases, as well as one of first publication to assess the introduction of anticoagulation, for example, of in case of cardioembolic stroke. If we follow the rule of 1, 3, 6, and 12 days prior administrating the anticoagulation, yet in such case series, we provided anticoagulation a little bit in an earlier phase and not following such rule. Because along the first waves of the pandemic, the D-dimer was usually considered as a sign of coagulation. And so we were obliged to administer anticoagulation fast enough. The third publication was a review on SARS-CoV-2 and stroke pathogenesis. All of us know that pathogenesis behind SARS-CoV-2 and its associated stroke are plenty and are diverse in presentation. Yet we were trying to analyze three main points, which are renin-angiotensin system and the angiotensin 2 converting enzyme downregulation, endothelial cell damage and coagulopathy, cytokine storm, and platelets. Let me first speak upon the renin-angiotensin system and the angiotensin converting enzyme 2 downregulation. In irregular circumstances, when there is a hypovolemia or there is hypotension, angiotensinogen, which is converted from the liver, is converted or acted upon by the renin that is secreted by the kidneys and convert it into angiotensin 1. Angiotensin 1 is converted by angiotensin converting enzyme from the lungs into the vasoconstrictor potent angiotensin 2. Such angiotensin 2 will cause a vasoconstriction in the blood vessels and will reverse the hypovolemia and the hypotension and restabilize the blood pressure. And after performing its action, it is usually converted or acted upon by angiotensin converting enzyme 2 receptor that are abundant within endothelial cells to angiotensin 1,7 that is a vasodilator. Unfortunately, COVID-19 entrance into the cells is through such angiotensin converting enzyme 2 receptors. And this causes a downregulation of such angiotensin converting enzyme 2 receptors with a result of an unopposed action of angiotensin 2. And this will result in an unopposed rise in the blood pressure that will ultimately may cause either form of strokes, whether hemorrhagic or ischemic. Entrance of COVID-19 into endothelial cells may cause damage into the endothelial cell lining, and this will cause dysfunction and disruption of the endothelial cells. Endothelial cells are responsible for secreting plenty of substances that are responsible for maintaining a blood clot, so as to stabilize a clot, or preventing excessive coagulation and thrombosis. And disruption and dysfunction of endothelial cells will cause thrombomodulin reduction, plasminogen activator inhibitor 1 overproduction, von Willebrand factor excess production, and all of these factors will be responsible for more coagulopathy, and also endothelial cell damage may aggravate platelet and cause them to be aggravated over the endothelial cells, and this will cause further thrombosis. Also, endothelulopathy and endothelial breakdown may weaken the blood vessel and causing a rupture in a blood vessel, and this will further be a responsible cause for hemorrhagic strokes. Also, endothelial cell lining, the entrance as the inner aspect of the cardiac muscle, and their damage may cause endocellulitis, may cause myocarditis and arrhythmia, and this will also may result in thrombosis and cardioembolic source for strokes associated with COVID-19. Inflammation enhances platelet to release its inorganic phosphate residue, which is termed poly-P. Poly-P stabilize clot and make it more resistant to lysis, and this will aggravate more ischemic stroke to develop. Also, cytokines and chemokines are released in excess to the novel virus with activation of macrophage, and net result more coagulopathy, endocellulopathy, and immunothrombosis. Another on the run stop was the fourth one, actually, was the pre-hospital causes for delay arrival in acute ischemic stroke before and during COVID-19. Along this publication that was published along PLOS-1, we analyzed cases that arrived prior to the declaration of COVID-19, and through a survey, we assessed the cause of delay in arrival behind 4 hours of the stroke onset. And once the stroke, the COVID-19 pandemic was declared, we also analyzed the cases that arrived beyond the window yet within the COVID-19 era. The commonest cause behind delay pre-COVID was receiving treatment in a non-stroke hospital, while the major cause in delay arrival in COVID was fear of infection and lockdown issues. Meanwhile, non-realization of urgency and stroke during sleep were common in COVID and pre-COVID periods. Along this publication, knowledge about stroke symptoms from media was also so obvious in the COVID period with a p-value of less than 0.001, which actually may be a possible way so as to increase awareness to stroke symptoms, whether in relation to COVID-19 or not related to COVID-19. Along this conclusion from the pre-hospital causes for delayed arrival in acute ischemic stroke before and during COVID-19 pandemic publication, we may use such results so as to increase awareness as I stated earlier. A case series of post-COVID-19 mycosis was also one of our Egyptian experience with COVID-19. The third wave in India revealed another complication associated with COVID-19, which is serious and nearly fatal if not managed properly and timely, which is mucormycosis. Mucormycosis is a rare opportunistic angioinvasive fungal infection that affects immunocompromised patients. And although not much reported in Egypt, yet it was encountered also along the third wave of the pandemic. In Shams University Specialized Hospital, which is the hospital where I am working, is a COVID-free hospital that do not deal with COVID cases. Yet we face post-COVID mucormycosis along cases that were suffering from uncontrolled diabetes or receiving large doses of steroid while being treated from COVID. The reason for calling neurologist and the stroke center involvement in such cases is actually so as to exclude cavernous sinus thrombosis. Yet, mucormycosis is a multidisciplinary team management emergency being managed by plastic surgery, neurosurgery, and ENT specialists. Along this case series, all cases suffered rhino-orbitocerebral form of mucormycosis, beside one case had an additional cutaneous form. Only one case had a cavernous sinus thrombosis that was responsible for the ophthalmoplegia that was suffering from. The rest had either orbital cellulitis or orbital apex syndrome that required involvement of the ophthalmologist besides the other specialties. Unfortunately, along this experience, one case died prior to any surgical debridement, and such case was the one who was suffering cutaneous form besides the orbitorhinocerebral form, and it was she was a female patient that presented to the ER of Ain Shams University Specialized Hospital after 21 days from the initial symptoms of ophthalmoplegia. And so it was obvious that she was presenting so late to be managed properly. The only case that was totally cured was the one with sinus thrombosis. Within this case series, we observed some interesting findings. Hyponatremia was detected along all cases with varying degrees. Low serum sodium is common with bacterial and viral infection, as we all know, yet it is rarely reported in fungal infections. One case had a reduction in visual acuity with evidence of demyelinating signal along ipsilateral optic nerve as well. The last two publications that were actually a multinational or multi-centric global publications. One was published in stroke and the other was published in neurology, were speaking upon SARS-CoV-2 and stroke characteristics and global impact of COVID-19 on stroke care and intravenous thrombolysis. From their conclusion, we found that COVID-19 actually hit the entire world so obviously or in a very serious way. So as the primary stroke centers as well as the tertiary stroke centers suffered a steep decline in cases presenting with stroke, whether because of fear of catching the COVID-19 or because of delay in arrival because of any other associated factors, yet such centers recovery was later on detected within the later months of the pandemic. Also, along the other publication, which was in the stroke journal, there was an evidence that large vessel occlusion was very common in COVID-19 associated strokes rather than small vessel occlusions. Finally, and although our hospital is a COVID-free hospital, as I stated earlier, yet COVID-associated stroke encountered in ER prior to referral to quarantine hospital, we observed that they are large vessel stroke, they were multi-territorial stroke, posterior circulation stroke, and presentation was with seizure was very common along such type of cases. And finally, thank you and stay safe. Get your vaccine dose to end the global experience with COVID-19 and stroke. And thank you.